Welcome back guys. Now in this video let's discuss about rheumatic fever and rheumatic heart disease. See, this topic is very important, especially from patho point of view. The same thing will come in the pediatrics and the same topic is also going to come in the internal medicine. So let's try to cover this topic in depth so that you can cover all the MCQs. Okay, we can cover all the MCQs as much as possible. Okay, having said that, so what exactly is this rheumatic fever? See, this rheumatic fever, it's an autoimmune disorder. Okay, so point number 1, it is autoimmune disease. Okay, so having said that, autoimmune disease, so it's going to be most common in males or females? See, all the autoimmune diseases are most commonly seen in the females. Okay, females are going to be most commonly affected than the males. Okay, so having said that, it's a autoimmune diseases. All the autoimmune diseases are example of which type of hypersensitivity reactions? They are example of type 2 hypersensitive reactions. Okay, so why it is called as hypersensitive, type 2 hypersensitivity reaction, we will discuss in a minute, but simple. Rheumatic fever, it's an autoimmune disorder which is an example of type 2 hypersensitivity reaction. It's going to be most commonly seen in the females when compared to the males. Okay, so which age group is going to be most commonly affected? The age group that's going to be most commonly affected is 10 to 15 years. Okay, so mostly this rheumatic fever is going to be seen in 10 to 15 years is the most common affected age group. Okay, so what exactly is this rheumatic fever? It's an autoimmune inflammatory disease. It is caused by an organism called as group A beta hemolytic streptococci. Okay, so there is this organism called as group A beta hemolytic streptococci, group A streptococcus. Okay, so why this organism is causing rheumatic fever and rheumatic heart disease, how it is causing and how it is causing this autoimmune disorder? Let me tell you, this group A beta hemolytic streptococci, even in that certain strains, not everything, is important, strains like M1, 3, 5, 6, 18. So these strains are responsible for the rheumatic heart fever. Now why rheumatic heart fever? What happens is, see, this group A beta hemolytic streptococci, first what they will cause is they are going to cause the strep throat or pharyngitis. So because of this infection, it's a upper respiratory tract infection. Okay, it's upper respiratory tract infection. Try to understand like this. Imagine that there is this 15-year-old boy, for example 10 to 15-year-old boy. Now this fellow, he got this group A beta hemolytic infection. This group A beta hemolytic streptococci entered into his body. And what it is doing? First it is causing the pharyngitis. Now secondary to this pharyngitis, first problem is pharyngitis. Secondary to this pharyngitis, the patient is going to develop the rheumatic fever. Okay, so rheumatic fever develops, let me write here itself, rheumatic fever develops secondary to pharyngitis. Why secondary to pharyngitis? Why pharyngitis is leading to rheumatic fever? I will tell you. But remember, this pharyngitis leading to rheumatic fever is seen only in 3% of the cases. Okay, the pharyngitis leading to rheumatic fever is seen in only 3% of the cases. Not in everyone. Not every child who gets this pharyngitis is going to develop the rheumatic fever. No, only 3% of the cases. This is the MCQ. Okay, why? What is the problem? The problem here, let me write the pathogenesis. So the pathogenesis in this condition is molecular mimicry. Okay, the problem is molecular mimicry. See, what is this molecular mimicry? This molecular mimicry is also called as a cross reactivity. Cross reactivity. So, what is cross reacting? Let me tell you. This is group A beta hemolytic streptococci. Okay, imagine this is a group A beta hemolytic streptococci. Okay, it's a cocci, right? Now, for example, imagine this is the group A beta hemolytic streptococci. Now, this group A beta hemolytic streptococci, on its surface, it's having a protein. Okay, it's having a protein on its surface. This protein is called as M protein. Okay, so let me write here. This protein is called as M protein. Okay. Now, whenever the child he gets this group A beta hemolytic streptococci, these streptococci are going to be attacked by the immune system, and the immune system is going to destroy the group A beta hemolytic streptococci, and the antibodies are produced. Okay. So, the antibodies are produced against this M protein, no doubt. Okay. But the point is, this M protein, it resembles M protein which is present on the group A beta hemolytic streptococci, M protein on the gas. Okay, group A beta hemolytic streptococci, it resembles what? It resembles N-acetyl glucosamine, which is called as NAG. So, N-acetyl glucosamine is something which is present on all our body cells. Okay, N-acetyl glucosamine is something intrinsic to us. This is something normally present in our body. Okay, but this M protein which is present on this bacteria, it is looking similar to N-acetyl glucosamine. So, whatever the antibodies which are produced against this M protein, these antibodies will not only now attack this M protein on the bacteria, but this M protein will also start to attack the N-acetyl glucosamine in our body. So, the N-acetyl glucosamine which is present in the joints will be affected, the N-acetyl glucosamine which is present in the heart, the N-acetyl glucosamine which is present in the central nervous system, all will be affected. So, that's the problem. It's a molecular mimicry. So, the M protein which is present on the bacteria, it is mimicking the N-acetyl glucosamine which is present on the human body cells. So, there is a mimicry. Because of this mimicry, because of this resemblance, there is a cross reactivity. The antibodies which are supposed to attack the M protein on the bacteria is now attacking our own body cells. That's why it's a hypersensitivity reaction type 2. Type 2 hypersensitivity reactions. Antibodies are attacking our own cells. Okay. Now, here itself I want you to know one point. See, even heart will be affected. This is a repeatedly asked question. That's why I am telling you in the beginning itself. What's the most common valve that is affected in the heart? See, the most common valve affected. We will discuss in detail, but here itself I am telling you the most common valve affected in heart. These antibodies will also attack the heart, leading to pericarditis, endocarditis as well as the myocarditis. But which valve of the heart is going to be most commonly affected? It's a mitral valve. Mitral valve is going to be most commonly affected, and least commonly affected valve in the heart is pulmonic valve. Pulmonic valve. So, after the mitral valve, aortic valve is going to be most commonly affected. Mitral valve followed by the aortic valve. The left sided valves are going to be most commonly affected. Okay. Now, after this, what else I should teach you? Let me tell you some basic points here itself. If the patient gets rheumatic fever, now imagine this is the 15-year-old guy. This 15-year-old guy first gets a group A beta hemolytic streptococcal pharyngitis. Now, after the pharyngitis, the patient is developing the rheumatic fever. Okay, he is getting the rheumatic fever. Why? The antibodies are not only attacking the microorganism, the antibodies start to attack the central nervous system. The antibodies start to attack the skin. The antibodies start to attack multiple places in the body. So, that's the rheumatic fever. Now, in this rheumatic fever, if heart is also involved, if heart involvement is there, okay, heart involvement. If heart involvement is there, then it should be called as rheumatic heart disease. If heart is involved in this process, if heart is also being affected, then it is called as rheumatic heart disease. If heart is not affected, then it is called as rheumatic fever, simple rheumatic fever. Okay. Now, this rheumatic heart disease is of two types. acute rheumatic heart disease, chronic rheumatic heart disease. Okay, acute rheumatic heart disease, chronic rheumatic heart disease. For example, see for the first time, okay, for the first time, the patient is getting this infection, group A beta hemolytic streptococcal infection. He is like, he's an unlucky fellow. He developed the rheumatic fever. Now, even this rheumatic fever, his heart is getting affected. So, for the first time, initially, then it should be called as acute rheumatic heart disease. Means initially he get the heart involvement. So, now tell me, he is going to have mitral valve involvement, and how the mitral valve will be affected? The patient is going to have mitral regurgitation. Okay, mitral regurgitation. So, initially, suddenly it's happening. So, for the first time, mitral valves are going to be affected, mitral valves are going to be inflamed. So, they do not close properly. As they are not closing properly, what happens? There will be regurgitation. They do not close properly because of the inflammation. So, there will be regurgitation. So, in acute rheumatic, remember, in acute rheumatic heart disease, there will be mitral regurgitation. But if they are talking about the chronic rheumatic heart disease, which means there are multiple episodes of the infection. Imagine I am a child who is 10 years old. For the first time I get the rheumatic heart disease. So initially I will have mitral regurgitation. Okay, after 1 year, again I get the beta hemolytic streptococcal infection. Again antibodies are produced. Again my heart is getting attacked. Again after 2-3 years, again I get the infection. Again heart involvement. So with the multiple episodes of rheumatic heart disease, the acute rheumatic heart disease will be converted into chronic rheumatic heart disease. So multiple injuries, injury upon injury, injury upon injury. So injury will heal, right? So in chronic rheumatic heart disease, okay, in chronic rheumatic heart disease, the patient is going to have mitral stenosis. Okay, the patient is going to have what? The patient is going to have the mitral stenosis. So in acute phase, the patient is going to have the mitral regurgitation. In chronic phase, the patient is going to have the mitral stenosis. So these are the important points which I want you to know. So what is the difference between rheumatic fever and rheumatic heart disease? Rheumatic fever is just a simple thing. The heart is not involved. If the heart is involved, then you have to call it as a rheumatic heart disease. In rheumatic heart disease also, initially if you have a problem, then it is acute rheumatic heart disease where the problem is mitral regurgitation. If you have multiple episodes of rheumatic heart disease, then you are going to have the chronic rheumatic heart disease where the patient is going to suffer with the mitral stenosis. Okay. Having said that, now in acute rheumatic heart disease, okay, in acute phase, now if you look at the biopsy of the heart, okay, here I am showing you the biopsy of the heart. Now what you are seeing, the antibodies are getting attacked. Now because of these antibodies, what's happening? There is inflammation within the heart, and there is a granuloma formation, okay, with multiple macrophages, lymphocytes, everything is coming, and this is an area of inflammation. So this area of inflammation, this inflammatory foci within the heart muscle is called as Aschoff nodule. So this is a very important MCQ. Now what do you see in acute rheumatic heart disease is Aschoff nodules. See, this Aschoff nodules, they are the pathognomic. See, they are the pathognomic of rheumatic heart disease, acute rheumatic heart disease. Now, not only that, see here I am showing you this is the Aschoff nodule, the inflammatory area which is called as the Aschoff nodule. Now, this Aschoff nodule, they will ask you, what exactly is this Aschoff nodule? It's a collection of what? It's actually a collection of lymphocytes. In that area of inflammation, you will see the lymphocytes, you will see the plasma cells, you will see the histiocytes. Histiocytes are seen, and collagen fibers swollen. Collagen fibers are seen. So all these are seen. Okay, and even the area is undergoing the necrosis. So it's which type of necrosis? Fibrinoid necrosis. So it's a necrotic area. Okay, and the inflammatory, the granuloma, it's actually a granuloma which is having the histiocytes, macrophages are there, lymphocytes are there. Okay, one more important point here is if you look at the macrophages in that area, okay, in the area of the inflammation, see these macrophages, they are having a ribbon shaped nucleus or the caterpillar shaped nucleus. So these caterpillar shaped cells, okay, these are nothing but the macrophages See, same in the Aschoff nodule only. In the Aschoff nodule only, you are going to have, see, in the Aschoff nodule only, you are going to have these caterpillar shaped cells, which are nothing but the macrophages. Okay, macrophages with caterpillar nuclei or ribbon shaped nuclei. See, these cells, they are called as Aschoff cells. Okay, MCQ, these are not the pathognomic, these are not specific. Why? Because Aschoff cells are seen in other conditions also. So, these are called as Aschoff cells. So, now tell me, Aschoff cells are nothing but the macrophages with the ribbon shaped nuclei. The macrophages with the ribbon shaped nuclei are the caterpillar shaped nuclei are the Aschoff cells, and Aschoff cells, yes, they are seen in the rheumatic heart disease. And what are the pathognomic feature or the pathognomic microscopic feature of this rheumatic heart disease is Aschoff nodules. Okay, Aschoff nodules. And what exactly are these Aschoff nodules? Aschoff nodules are nothing but the granulomas. They are the inflammatory foci with lymphocytes, plasma cells, histiocytes as well as the swollen collagen fibers. Now, after that, what else you will see? See here, you are able to see this area which I am highlighting. Okay, so this area is called as a McCallum plaque. This was image based question which was given in many of the exams. Okay, later I will talk about this McCallum's plaque, why there is McCallum's plaque. Okay, I will discuss about this later. So, first, what are the criteria? How to put the diagnosis that this fellow or this child is suffering with rheumatic fever? What is the criteria? The criteria which is followed is called as the revised Jones criteria. Okay, the revised Jones criteria is a criteria for the diagnosis. According to this revised Jones criteria, what are they? The individual or this child should have the history. He should have the history of group A beta hemolytic streptococcal infection. So, history should be positive. Along with this history, positive history, there should be 2 major criteria and 2 minor criteria. Okay, so 1 major or 2 minor. See, for example, if you want to say that I am the person who is suffering with, okay, this fellow is suffering with rheumatic fever, then I should have a positive history of group A beta hemolytic streptococcal pharyngitis along with 1 major criteria. Sorry, 2 major criteria. What are these major criteria? We will discuss later. There should be positivity of 2 major criteria or at least 1 major criteria along with the 2 minor criteria. So, this is the revised Jones criteria. Okay, so tell me, revised Jones criteria is used to establish the diagnosis of rheumatic fever. And what is the criteria needed? History of group A beta hemolytic streptococcal infection, history should be positive along with the 2 major criteria. If 2 major criteria are not there, at least 1 major criteria should be there along with 2 minor criteria. So, what are these major criteria and minor criteria? We will discuss. Okay. Sounds వస్తున్నాయి అని ఇదే మీరు కదలడం వల్లే అనుకుంటా చూసుకోండి. Now, let's talk about the major criteria. See, what are these major criteria? Remember the criteria, there is a mnemonic. The mnemonic which I want you to know is Jones criteria. Jones. So, the name of the criteria is Jones criteria, okay, and the mnemonic is also Jones. The major criteria Jones. So, what is this JONES if you ask me? J stands for joint involvement. The joints are going to be involved. That's a migratory polyarthritis. Okay, multiple joints are going to be involved. This O, which I have shown in the form of a heart shape, this is the heart involvement. Heart will be affected. Okay, involvement of the heart. Okay, whether the heart is involved or not. And N starts for nervous system involvement. Okay, the nervous system involvement, which is present as a chorea. Okay, abnormal movements. And E stands for erythema marginatum, rash. Erythema marginatum, which I will show you. Don't worry. And S stands for subcutaneous nodules. Okay, under the skin, nodules are there. So, now let's begin our topic with this major criteria. We will discuss about 1 by 1 major criteria. First, I want to start with the heart involvement. This is important. Let's start with the heart. So, what is this heart involvement, sir? Look here. So, if a patient is having rheumatic heart disease, okay, rheumatic heart disease, which part of the heart is going to be affected? Is it pericardium going to be affected, myocardium or endocardium? Which part of the heart is going to be affected? So, all 3 layers of the heart is going to be affected. Then that's why it is called as pancarditis. Okay, pancarditis. All pericarditis is going to be there along with that myocarditis as well as endocarditis. Okay, so both all the three pericarditis, myocarditis, endocarditis is going to be there. Now let's discuss one by one. For example, because of these antibodies are attacking the heart. Now the pericardium is also having the N-acetyl glucosamine, so pericardium will also be affected. So pericarditis is seen. Now if this fellow is having pericarditis, okay, you can look, you can see here, this is the pericardium of the heart, which is inflamed, total inflamed. And how it is looking? It's looking like something kind of a cheesy, buttery thing, like, right? Okay, so that's why it is called as bread and butter pericarditis. First point number one. I'm talking about the pericarditis now. Okay, so there is bread and butter pericarditis. Okay, bread and butter pericarditis is an example of fibrinous pericarditis. Okay, it's a type of fibrinous pericarditis. Okay, bread and butter pericarditis is an example of fibrinous pericarditis. Now, imagine I am a baby. Okay, imagine I am a baby who is having this rheumatic heart disease. Now, my pericardium will be affected or not? Yes, my pericardium will be affected. When my pericardium is affected, yes, it's looking like a bread and butter pericarditis is a type of fibrinous pericarditis. Now, if you do the auscultation of the heart, definitely, see, the pericardium is inflamed, right? With every heartbeat, it is rubbing. This inflamed pericardium is rubbing over the heart wall. So, that is going to cause pericardial friction rub. So, upon auscultation, what do you hear? What you hear is a pericardial friction rub. So, pericardial friction rub is going to be positive. Now, what kind of ECG changes are going to be seen? If a patient is having the pericarditis on ECG, what you can appreciate? You can appreciate that the ST segment elevation is going to be seen. Okay, ST segment elevation. So most of the students, they only know that the ST segment elevation is going to be seen in the STEMI, like ST segment elevated MIO, not only in myocardial infarction, but even in the conditions of pericarditis also, the ST segment is going to be elevated. Okay, ST segment elevation is going to be elevated. That's the point which I want you to know. Okay. Next, what is the treatment? Treatment of this pericarditis. The treatment of this pericarditis is steroids. Okay, steroids are used. I'm just trying to integrate as much as possible with the medicine. So, steroids are used to treat this pericarditis. Okay, it's a painful condition. Now, let's talk about the myocarditis. Not only pericardium, myocardium will also be affected. Now, let's talk about the myocarditis. So, myocardium is affected. Whenever there is myocarditis, the myocardium, the heart muscle, now it is not going to contract properly. When it is not going to contract properly, what will happen? That can lead to acute congestive heart failure. So, congestive heart failure can be seen, that can lead to pulmonary edema. The heart is now failing, it is not contracting properly. When it is not contracting properly, the back pressures are generated, the congestion is going to happen, that can lead to the pulmonary edema, and because of that pulmonary edema, the patient can have dyspnea. Okay, so this is a problem. So myocarditis is actually going to kill the patient, especially in long term, in chronic phases. This myocarditis can kill the patient. Okay, so myocarditis can lead to acute congestive heart failure, that can lead to pulmonary edema. And how to treat this myocarditis? Myocarditis is treated, it's like there is a congestion, right? There is congestion of the blood. So it is treated with the drugs like Lasix, diuretics. Lasix, L stands for Lasix, M stands for morphine, N stands for nitrates. Nitrates, why? Because nitrates decrease the preload on the heart. Whenever you give the nitrates, there will be venodilation. Whenever there is a venodilation, the preload or the venous return to the heart decreases. So the load on the heart decreases. Okay, already the heart is failing. There is myocarditis, there is acute congestive heart failure. So what you need to do, you need to decrease the load on the heart. To decrease the load on the heart, you need to give the nitrates. Nitrates cause the vasodilation or venodilation. Whenever there is venodilation, venous return decreases, preload decreases. So automatically the load on the heart decreases. Okay, so Lasix, which is a diuretic given, so it decreases the blood volume in the body, it treats the congestion. Morphine can be used, and nitrates can be used, and oxygen. Okay, oxygen can be used because this patient is not having enough amount of oxygenation, right? There is congestion. Because of the congestion, oxygenation will decrease. So oxygenation can be done. And the P stands for position. The patient is now set, like with the will decrease the blood flow. He is going to be now in this position, not in exactly supine position. Now the bed is going to be elevated like this. So what happens? Venous return decreases. Venous return decreases. Okay, so the patient is not exactly in supine position. Now he is like this. So the blood is going to gravitate down. The venous return decreases. The load on the heart decreases. Okay, so what we have discussed? We have discussed the first major criteria. What is the first major criteria? The first major criteria right now I am discussing is the pancarditis, the heart involvement. So which layers of the heart is going to be involved? All the 3 layers of the heart is going to be involved. There will be pericarditis, myocarditis as well as the endocarditis. Pericarditis is going to be bread and butter pericarditis with the frictional rub, pericardial frictional rub with the ST segment elevation on the ECG, and it will be treated with the steroids. Myocarditis can lead to acute congestive heart failure, and that can be treated with LMNOP drugs. Okay, Lasix, morphine, oxygenation, nitrates, these things. And the last one is the endocarditis. Endocardium is the innermost layer of the heart. Even the heart walls, the mitral valve, tricuspid valve, okay, aortic valve, all they are made up of the endocardium. Remember, walls, heart walls are made up of the endocardium. So whenever there is endocarditis, let me write here, endocarditis. So valves are going to be affected. Endocarditis is going to present as valvulitis. Okay, it's going to present as the valvulitis. The valves are going to be affected. Which valve is going to be most commonly affected? The most commonly affected valve is mitral valve. Okay, mitral valve is going to be most commonly affected. That too I have taught you in acute phase. In acute phase, there will be mitral, initial phase, there will be mitral regurgitation. Okay, there will be mitral regurgitation. Because of the mitral regurgitation, whenever the mitral valves are not closing properly, what will happen? There will be regurgitation of blood back into the left atria. Now this regurgitation of the blood is going to definitely cause a murmur. So what is that murmur? So the patient with the acute mitral regurgitation, he is going to have the holosystolic murmur. Okay, so this mitral regurgitation is going to cause the holosystolic murmur. Okay, not only that, see, because of this regurgitation, look here, I have shown you from the left ventricle, see the blood from the left ventricle, it is going to regurgitate back into the left atria. Okay, the mitral valves are not closing properly, there is a regurgitant jet of blood. This regurgitant jet of blood is going to come into the left atria. So this regurgitant jet of blood is going to hit on the wall, it's going to hit on the wall of the left atria. Okay, so that's going to cause a plaque or a patch here. So this is called as McCallum's plaque. Okay, this McCallum's plaque, yes, it is seen in left atria posterior wall. Why? Why? Because of the mitral regurgitation. Okay, now you can see here, see if this is the left ventricle. Now what is this wall? These are the mitral valves. Okay, now what is this chamber which is present on the top? This is the left atria, this is the left ventricle. Now what is this wall? This is the mitral wall. Now is it closing properly now? No, it's not closing properly because of the endocarditis. Because of the endocardial involvement, the mitral valve is inflamed, it is not closing properly. When it is not closing properly, what happens? The regurgitant jet, because of the, see, when the left ventricle contracts, when the systole, when the left ventricle is contracting, there will be regurgitation of blood back into the left atria that's going to hit hard onto the wall of the left atria posterior wall, leading to McCallum's plaque. Okay, McCallum's plaque is going to be seen. Next, what else are the important points which you need to know? See, these mitral valves, they are inflamed. Okay, these mitral valves are inflamed, they are beating. Okay, already they are beating, they are inflamed and they are beating. So what happens? There will be damage. Okay, whenever they are closing, they are inflamed and they are closing. So what happens? So there will be a damage. Because of this damage, what will happen? So there will be formation of small thrombi or vegetations. See, some damage is happening. Over the damage, some small clots are going to form. Okay, these are called as the vegetations. So that's why when you look at the mitral wall, look here. See, this mitral wall on its edges along the line of closure, the word they will use in your exam is along the lines of closure. So along the lines of closure, what you are able to see here is small platelet microthrombi. These are nothing but the vegetations. So tell me, vegetations are seen, these vegetations, they are sterile. Okay, they are not having any microorganism. See, there is no microorganism. Even the heart, there is no microorganism. It's an autoimmune disorder, remember. Auto-antibodies are attacking. Because of the damage, because of the inflammation, see these inflamed walls are beating and they are getting damaged, and you are going to have what? Platelet microthrombi. And these are the small vegetations. And do you see any microorganism over there? No. So that's why these vegetations, they are sterile, and where they are seen along the line of closure. Okay, so with repeated attacks, so mitral regurgitation happening, okay, and it will be healed. So the walls are going to be healed with fibrosis. So with the time, what happens? The mitral walls are going to be calcified and there will be stenosis. See here, the mitral wall, it is calcified. It's now not opening properly. It is stiffened. It is narrowed, and it's almost looking like a fish mouth. It's looking like a fish mouth. It's stenosed. So there is fish mouth stenosis. With the time, that is a chronic rheumatic heart disease. In chronic rheumatic heart disease, there will be fish mouth stenosis. But in acute phase, there is mitral regurgitation. Chronic phase, there is mitral stenosis. And how it looks like? It looks like a fish mouth. And along the lines of closure, what do you see? Vegetations. These vegetations are the septic or sterile? They are sterile vegetation. They are just nothing but the platelet microthrombi. Okay, and what else you will see? Pericarditis, it's looking like what? The pericarditis, it's looking like a bread and butter, so it is bread and butter, pericarditis. And the left atria, what you will see? In the left atria, what you can see is a McCallum's plaque. It is because of the regurgitation, mitral regurgitation. And this mitral regurgitation is going to cause a murmur, and what is that murmur? It's a holosystolic murmur. Okay, it's holosystolic murmur. Not only that, I just want to add one more point here, that there is something called as flow murmur. See, in this rheumatic heart disease, yes, there is a holosystolic murmur because of the mitral regurgitation. Mitral regurgitation is going to cause the holosystolic murmur, okay, no doubt. Not only that, see, there is a flow murmur called as Kerry-Coombs murmur. So what exactly is this Kerry-Coombs murmur? It's a flow murmur. See, this regurgitant blood have came into the left atria, right? Some extra amount of blood came into the left atria, right? So this extra amount of blood again will come down. So the extra volume of blood that is coming from the left atria to left ventricle back. So this flow of this extra volume of blood is going to cause a murmur, and that is called as a flow murmur. Okay. So Kerry-Coombs murmur is a flow murmur which is heard during diastolic phase. During diastole, that extra amount of blood will come down. So it's an example of mid-diastolic murmur. Okay, so it's an example of mid-diastolic murmur. So tell me, in rheumatic heart disease, how many types of murmurs are seen? There are two types of murmurs. Very important murmur is this Kerry-Coombs murmur. Kerry-Coombs murmur is a mid-diastolic murmur. It's a flow murmur. The extra blood what have gone into the left atria because of the mitral regurgitation, that extra blood will again come down. That extra flow of blood which is coming down into the ventricle will cause this Kerry-Coombs murmur. And because of the mitral regurgitation, during systole you will hear a murmur that is called as a holosystolic murmur. Okay. So with this, the important points regarding the pancarditis are completed. Okay, the first criteria completed, pancarditis is completed. Okay, so now tell me, in Jones, one criteria we have accomplished. Next one, let's talk about the joints, joint involvement. So what is this joint involvement? It is migratory polyarthritis. Migratory in the sense means what? For example, initially this fellow, 10-year-old guy, he is going to have involvement, so arthritis, for example in the elbow joints. Okay, after some time, after a week, the patient is going to have involvement of this shoulder joint. After some time, the patient is going to have involvement of wrist joint. After some time, hip joint, knee joint. So larger joints are going to be involved, and the involvement of the joints is skipping, like migrating from one joint to other joint. So inflammation of small joints or large joints? Large joints. Okay. See, rheumatic heart disease or rheumatic fever is different. Rheumatoid arthritis is different. Rheumatoid arthritis is a total different thing. Rheumatoid arthritis is going to affect the smaller joints. Rheumatoid arthritis. This is rheumatic fever. It's an autoimmune disorder. Okay. See, inflammation of the large joints, that too migrating. Okay. So the point which I want you to know is multiple joints are involved, and they are migrating from one joint to other joint, and this is the most early presentation. It's the most early presentation. If a patient gets the rheumatic fever, what is that first he is going to manifest? The first manifestation is going to be, let me write here, first manifestation. Okay, if a person gets the rheumatic fever, then the first manifestation is going to be the migratory polyarthritis. After migratory polyarthritis, he can develop the pancarditis, after that Sydenham's chorea, after that something like that. But the first is going to be migratory polyarthritis. Okay. Now, in high risk areas, see, in the countries like India, where the rheumatic fever cases are more, okay, you don't need to have the migratory polyarthritis. You don't need a migratory polyarthritis. This is an update. You can have a monoarthritis. Even monoarthritis in high endemic regions. Monoarthritis in high endemic regions can be considered as a major criteria. Okay. See, normally according to the major criteria, there should be migratory polyarthritis. But an exception is in high endemic areas, in developing countries where the cases of rheumatic fever are more. In such areas, even monoarthritis can be considered as a major criteria. Okay. So that's the important point which I want you to know. And how to treat this migratory polyarthritis? See, one more point which I want you to know is, see, arthritis is there, the joints are going to be involved. See, will there be any deformity in the joints? No, it's a non-erosive. It's a non-erosive condition, which means joints are not damaged. For example, if you get the rheumatoid arthritis, in the condition of rheumatoid arthritis, it's an erosive arthritis. The joints are going to be damaged. But here in migratory polyarthritis, these are non-erosive arthritis. And how it is going to be treated? The treatment is done with aspirin or naproxen or non-steroidal anti-inflammatory drugs. So the non-steroidal anti-inflammatory drugs are aspirin. These are the drugs used for the treatment of migratory polyarthritis. Okay, so tell me, migratory polyarthritis is going to involve the large joints and multiple joints are going to be involved. It's the earliest manifestation in rheumatic fever. Earliest manifestation, the first affected things are going to be the joints, because of this auto-antibodies are going to affect the joints. And in high endemic areas like India, where the cases of rheumatic fever are very much common, just monoarthritis can be considered as a major criteria. Okay. And here also I want to add one more point. See, in high endemic areas, okay, let me write here itself. In high endemic areas, no need to get the pancarditis, valvular involvement for the major criteria. No need to get the pancarditis, pericarditis, myocarditis or endocarditis. No need to get all these things. So, in high endemic areas like India, no need to involve all this pancarditis. No need to have the mitral valve involvement. Just on echo, if you find valvulitis, See the features of valvulitis, which means valve is getting affected, valve is getting inflamed. Just simple valvulitis, the features of valvulitis can be taken as a major criteria. No need to develop the pancarditis, myocarditis, endocarditis. Just simple valvulitis and echo can be considered as a major criteria in high endemic regions. Okay, so that's the one point which I want to add. So migratory polyarthritis, also monoarthritis in India can be considered as a major criteria. Okay, now after this, Sydenham's chorea. Sydenham's chorea, what exactly is the Sydenham's chorea? It is involuntary rapid purposeless movements. Okay, it is involuntary rapid purposeless movements. Okay, this is a late manifestation. The late manifestation out of all the JONS is the Sydenham's chorea only. So Sydenham's chorea is the late manifestation. Earliest manifestation is what? The first manifestation or the earliest manifestation is migratory polyarthritis. But the late manifestation, it is going to be seen after 3 months, mostly after 4 months or 5 months or 6 months. So if on first month, if there is migratory polyarthritis, after 6 months, the patient is going to develop the Sydenham's chorea. So there is no chance that the migratory polyarthritis and Sydenham's chorea, they are going to be coexisting. Okay, by the time the patient develops the Sydenham's chorea, the migratory polyarthritis is resolved. Okay, it's a self-resolving condition, right? Migratory polyarthritis is a self-resolving condition. By the time the patient Sydenham's chorea is developing, the patient is totally resolved, cured from the migratory polyarthritis. So the point which I want you to note here is, take a note. Note arthritis and chorea. Sydenham's chorea cannot coexist. Why? Because one is the earliest manifestation, arthritis is the earliest manifestation, and chorea is the late manifestation after 3 months, 4 months. So they cannot coexist. Okay, that's the point which I want to know. What exactly is chorea? Chorea is the purposeless, fast, involuntary movements. Now, because of this, in a child, and a 10-year-old child, what can be seen? See, because of this purposeless movements, the patient is going to have poor handwriting. Okay, poor handwriting. Okay, bad school grades are going to be there. If you do the examination, whenever you do the examination, so on examination, there will be darting tongue. Darting. Because involuntary movements, when you ask the patient to show the tongue, it's going to be like a darting tongue. Okay, it's moving, it's a darting tongue, like a snake. There will be darting tongue. If you ask the patient to have a grip, okay, he cannot have a powerful grip. Okay, there will be a darting grip, darting tongue and milk-made grip. Milk-made grip. Because of this central nervous system involvement, the reflexes are not going to be proper, they will be hung up. Reflexes will be hung up reflexes. So upon doing the examination, because of the central nervous system involvement, the patient is going to have unnecessary rapid purposeless movements. These are called as the chorea. So whenever you do the examination of this patient, the patient is going to have darting tongue, milk-made grip and hung up reflexes. And even this Sydenham's chorea, it's a self-resolving condition, self-resolving. It's a self-resolving condition. It will go up on its own. Okay, if you want to use drugs, you can use drugs like the CNS depressants like valproate, haloperidol. These drugs can be used, valproate, haloperidol, phenobarbital, these drugs can be used. So even after 6 months, the chorea is not going out. Okay, it's not self-resolving. Even with the usage of drugs, it is not going. So then it is called as medically refractory chorea. Medically refractory chorea. See, in this medically refractory chorea, then you can use drugs like IV, IG, intravenous immunoglobulins. So intravenous immunoglobulins are used for medically refractory chorea. So these are the points which I want you to know. So the earliest manifestation is the migratory polyarthritis, true, and the late manifestation is the Sydenham's chorea. Both this migratory polyarthritis and Sydenham's chorea, they are not going to coexist, because one is the earliest manifestation, other is the late manifestation. Both these conditions are self-resolving. One is treated with the non-steroidal anti-inflammatory drugs, that is the arthritis is treated with the non-steroidal anti-inflammatory drugs, and for the chorea, you don't need to give any drugs, but you can also use drugs like the CNS depressants like valproate, phenobarbital, haloperidol. But for medically refractory chorea, even after giving drugs, if the chorea is not going away, then you can use drugs like intravenous immunoglobulins. And because of this chorea involuntary movements, the baby or this 10-year-old boy who is a school going child, he is going to have a poor handwriting that can lead to bad school grades, and upon doing examination, the grip is called as a milkmaid grip. He is not going to have a powerful grip, it's like a very soft grip, it's a milkmaid grip. Okay, milkmaid grip is going to be there, darting tongue is going to be there, and his reflexes are going to be very much decreased, hung up. Now, what else are there? Now, in the Jones criteria, in the major criteria, J completed, there is a migratory polyarthritis, this is completed, and this heart involvement is also completed, O completed. Now, even this nervous system involvement, there is a Sydenham's chorea. Okay, nervous system involvement, Sydenham's chorea is also completed. Now, let's talk about the S. This is the subcutaneous nodules. Okay, subcutaneous nodules, and E, erythema marginatum. Now, let's talk about them. See here, you are looking at subcutaneous nodules. So, the patient is going to have, because of the skin involvement, the antibodies are also attacking the N-acetyl glucosamine under the skin, that can lead to the subcutaneous nodules, and the baby is also going to have a rash. If you look here, the baby is also going to have a rash, especially in the margins. Okay, the central area of the rash is now pallor, only the outermost regions are having this erythema. So, this is called as erythema marginatum. Okay, the patient is going to have erythema marginatum. So, subcutaneous nodules and erythema marginatum, they are also considered as a major criteria. So, with this, I have discussed all the important major criteria. So, tell me, what are the major criteria? The first major criteria which I have discussed is the pancarditis. The second major criteria which I have discussed is the migratory polyarthritis. The third major criteria is the Sydenham's chorea. Fourth major criteria and fifth major criteria are the erythema marginatum and subcutaneous nodules. See, don't think that all the major criteria will be there. A patient, if I am a 10-year-old guy, I may have one or two of the major criteria. No need to have all the major criteria. Just one or two major criteria can be there, or three or four major criteria. Like, see, it's like a mixture. Okay, anything can be possible. For example, I can have erythema marginatum or subcutaneous nodules, or there can be heart involvement or the joint involvement. So, anything, any kind of mixture is possible. Okay. Now, look here. So, diagnosis is revised Jones criteria. Now, another revised Jones criteria, history of group A beta hemolytic streptococcal infection, you know it. The patient is having group A beta hemolytic streptococcal infection. And how can we know that the patient had a group A beta hemolytic streptococcal infection? Just like laboratory test, blood test. So, if you have anti-DNase antibodies, okay, the anti-DNase antibodies are anti-streptolicensed, anti-streptolicin O titers. If they are present, these are the antibodies. Okay, these are the antibodies. So, if you have these antibodies in the blood, it indicates, yes, this fellow had infection. This fellow is having the infection of the group A beta hemolytic streptococcal infection. Because of that, these antibodies are present. These antibodies are produced against the streptococci. Okay, and okay, this is completed. The major criteria also completed. I have discussed all the 5 major criteria. Now, what I have to discuss? I have to discuss about the minor criteria. So, what are considered as the minor criteria for rheumatic fever? The minor criteria, there are 5 minor criteria. One is polyarthralgia. Polyarthralgia. See, not polyarthritis, migratory polyarthritis. Inflammation of joints is considered as a major criteria. This is just arthralgia, just joint pains. Okay, polyarthralgia, fever. How much? More than 38.5 degrees centigrade. Even there is a little change in the value in high endemic regions and low endemic regions. Just remember this thing. And ESR, elevation of the ESR. Okay, ESR, how much elevated? ESR elevated more than 30 mm fall. If there is more than 30 mm fall, then it's considered as a major. It's considered as a minor criteria. And CRP, reactive protein elevated. See, they are all suggesting the inflammation in the body more than 3 milligrams per deciliter and prolonged PR interval. See, prolonged PR interval in EKG. Prolonged PR interval in EKG is also considered as a minor criteria. Why? Because these Aschoff nodules are there. These Aschoff nodules are coming and sitting in the way of the conduction system. So the electrical impulse from the SA node to AV node, it is not properly being transmitted. So because of this Aschoff nodules, so it's taking a lot of time. So PR interval is prolonged. So what I'm trying to put into your mind is, imagine this is the SA node and here is the AV node. Okay, see, this is SA node, this is the AV node. Now in between them, here what is sitting, the Aschoff nodules are sitting. Because of the presence of this Aschoff nodules, this granulomatous inflammatory areas, now it is taking for the electrical impulse to travel, now it is taking, these are acting like a speed breakers, now it is taking a lot of time. So what happens, the PR interval in the ECG or the EKG also increased. So these are considered as a minor criteria. So what are the minor criteria? Polyarthralgia, fever is there, elevated ESR, C-reactive protein, and prolonged PR interval. These are the minor criteria. So now tell me, how to put the diagnosis that this fellow is having rheumatic fever? At least 2 minor criteria should be there, or at least one minor criteria, at least one major criteria with the 2 minor criteria. At least two majors or one major with the 2 minors. So this is the revised Jones criteria. If the patient is fulfilling all these criteria, yes, he is having rheumatic fever. If heart is involved, then it is rheumatic heart disease. Okay. So what is the treatment part? Now already we know that the arthritis is treated with the aspirin or the non-steroidal anti-inflammatory drugs. Pericarditis is treated with the steroids. Chorea is treated with the valproates, haloperidol, phenobarbital. If it is a medically refractory chorea, then we can treat it with the intravenous immunoglobulins. But now imagine a 10-year-old guy, a 15-year-old guy, he is coming to your clinic. Now he is having rheumatic fever. Now what you are more concerned about? Now if he is having rheumatic fever or rheumatic heart disease, his heart is also affected, his heart is involved, then he is having rheumatic heart disease. Initially, this is the first attack. So this is definitely acute rheumatic heart disease. Okay, acute thing. Now what you are more worried is, if in the future, after 1 year or 2 years, in the future, if he develops one more attack, this acute rheumatic heart disease, it will be converted into chronic rheumatic heart disease. More and more insults will convert the mitral regurgitation into more severe condition called as a mitral stenosis. So what you are more worried about? You are more worried about the future infections. You have to prevent the future infections. Okay, you know the symptomatic management. I have shown you how to treat the migratory polyarthritis, how to treat the Sydenham's chorea, how to treat the pancarditis. That's done. What is more important is what we need to do to this patient. We need to prevent the future attacks. Okay, so IV benzathine penicillin. To prevent the future attacks, this patient have to take this antibiotic which is called as intravenous, okay, injections. This injection of the benzathine penicillin, not IV, sorry, it's the intramuscular benzathine penicillin injection should be taken every 3 weeks. Once in every 3 weeks. Every 3 weeks, you have to go to the hospital and have to take an injection. Intramuscular benzathine penicillin. Till how much time have to take? Till lifelong. That's the best answer. So lifelong, you have to give him intramuscular benzathine penicillin. So what we need to do? We have to give lifelong. See here, lifelong treatment. It is ideal. And lifelong, what we have to give? IM benzathine penicillin. Why IM benzathine penicillin? What it is doing? It will prevent the future sore throats. It's acting like a prophylaxis. We are preventing the future attacks. Okay. So some important MCQs which I want you to know is, if a patient is having, see, lifelong is not practically possible, right? Lifelong is not practically possible. Now imagine he is a 10-year-old guy. For example, he is living till 80 years. So for the next 70 years taking intramuscular benzathine penicillin, so it is not practically possible. So what we can do, if a patient is having rheumatic heart disease, look here, rheumatic heart disease, the two valvular lesion is there. Okay, rheumatic heart disease, heart is involved, but the valves are also involved, which means the endocarditis is there. Rheumatic heart disease means just only pericarditis can be there, or there can be myocarditis. So, rheumatic heart disease, heart is involved, but valves are also involved, endocardial involvement is there. Now in that case, the next best answer, if not lifelong, at least you have to take 40 years. From that time, from now, for the next 40 years, you have to take the IM benzathine penicillin. If in your question, if they give rheumatic heart disease, heart is involved, but valves are not involved. Just for example, pericarditis is there, myocarditis is there, but endocarditis is not there. Now in such condition, rheumatic heart disease without the valvular lesion, then at least 21 years you have to take the intramuscular benzathine penicillin. For example, if they talk about only rheumatic fever, heart test is not at all involved, sir. Only migratory polyarthritis is there, Sydenham's chorea is there. Only these two are there. Then at least again 21 years of intramuscular benzathine penicillin should be taken. So these are some important points. This is the prophylaxis. The prophylaxis is intramuscular benzathine penicillin once in every 3 weeks till lifelong. If lifelong is not there in the options, then I have given you, okay, some other alternatives also. Now, for example, if this child, okay, I am benzathine penicillin, right? What if this child is having penicillin allergy? Now, if the patient is having penicillin allergy, then this patient should have to take some other antibiotics like macrolides, like azithromycin. So, azithromycin is used in the patients who are having penicillin allergy. Next, if the penicillin allergy is there, you don't know that this fellow is having penicillin allergy. So, you injected benzathine penicillin. Okay, you have injected the benzathine penicillin. Now, what will happen? So, the penicillin is going to cause the anaphylaxis. Penicillin allergy will occur. Now, how to stop this allergy is adrenaline, simple, it's an anaphylactic, like an anaphylaxis is happening, anaphylactic shock is happening. So now you need to inject him adrenaline, intramuscular adrenaline in 1:1000 concentration. So undiluted intramuscular adrenaline will be given. Otherwise what will happen is the patient will die. Okay, die with the anaphylaxis, because this anaphylaxis can lead to laryngeal edema, the patient cannot breathe, and that can lead to the death of the patient. So what I am trying to put into your mind? Simple. Prophylaxis is done with intramuscular benzathine penicillin. If the benzathine penicillin is having allergy, the patient is having allergy with the benzathine penicillin, then the next best antibiotic which you can choose for the prophylaxis is macrolide, that is the azithromycin. Without knowing that this patient is having penicillin allergy, if you inject intramuscular benzathine penicillin, what will happen? Penicillin allergy will occur. That can lead to anaphylaxis. So how to stop this anaphylaxis? How to stop this, allergic reaction? Is undiluted intramuscular adrenaline should be given. Okay. Otherwise, if you don't give, the patient will die with laryngeal edema. Okay. So the cause of death in anaphylaxis is laryngeal edema. So with this, all the important topics about the rheumatic fever are completed. Okay. I have tried to integrate as much as possible with the other medicine related to topics also. Hope the video is helpful. In the next video, let's discuss about the infective endocarditis. Thank you.